All right, let's talk about syncope. This is one of those chief complaints you're going to see everywhere in medicine, right? From the clinic to the middle of a chaotic ER shift. Honestly, getting a handle on it is totally non-negotiable. So let's break down exactly what you need to know.
So why should you really care about this topic? Well, get this. Syncope accounts for a whopping 1 to 3% of all ED visits. Think about that for a second. That is a massive slice of the acute care pie. Getting the diagnosis right isn't just important, it's absolutely critical.
Okay, so what are we actually talking about when we say syncope? The official definition really nails the core features for us. It's a transient, and that's a key word, loss of consciousness. And it's all because of a sudden, temporary drop in blood flow to the brain. You got to remember three things here. The onset is super fast. The whole thing is really short, and the recovery is complete and happens all by itself. If a story doesn't tick all three of those boxes, you might be dealing with something else entirely.
All right, first up, let's really get into the nitty-gritty of what's happening on a physiological level when someone faints. I promise you, if you can grasp this core mechanism, everything else is going to click into place.
When you boil it all down, the problem is actually pretty simple. For a brief moment, the brain just isn't getting enough blood, and poof, the lights go out. So our real job as clinicians, is to play detective and figure out why. Why did that blood flow suddenly take a nosedive?
So how does our body usually prevent this? Well, check this out. We have this incredible built-in system called the baroreflex. The best way to think about it is like a thermostat for your blood pressure. You've got these little sensors in your major arteries, and they're constantly checking the pressure. If it changes, they shoot a signal to the brain, which then adjusts your heart rate and how tight your blood vessels are to keep everything stable. Pretty cool, right? Well, syncope often happens when there's a glitch in that circuit. A misfire or some trigger that just completely overwhelms the system and causes it to fail.
Okay, so there are a ton of things that can cause syncope, and it can feel kind of overwhelming. That's why we need a simple, clear framework to think about it. Clinically, the best way to tackle this is to sort every single case into one of three big buckets. And these buckets are all based on the underlying mechanism. And here are our three main culprits. First up, we've got neurally mediated syncope, which you'll also hear called reflex syncope. Second is orthostatic hypotension, and the third, the big one, is cardiac syncope. Look, just about every single patient who faints is going to fit neatly into one of these categories. So your first job is to figure out which bucket does this person belong in.
Okay, let's dive into the first two categories, because these are by far the most common ones. Now, I should say they're not always totally benign, but they are the ones you're going to be seeing day in and day out.
So what's the real difference between these two? It's actually a pretty neat distinction. Think of it like this. Neurally mediated syncope, that's an overreaction. Some trigger makes the body freak out and slam the brakes on both heart rate and blood pressure. On the other hand, orthostatic hypotension is a failure to react. The person stands up and the body's reflexes just don't show up to the party. They don't kick in like they're supposed to, and gravity wins. And this is where it gets really cool, because we can actually see the hemodynamic fingerprints of these two types. Just look at this. On the left, for neurally mediated syncope, you see the sudden, dramatic cliff dive in both blood pressure and heart rate. Bam! Everything drops. But now look at the right. With orthostatic hypotension, the blood pressure kind of slowly drifts down, but notice the heart rate? It just doesn't ramp up enough to fix the problem. Seeing these patterns side by side really hammers home that difference between an overreaction and a failure to react.
Okay, let's pause here, because we're moving on to the most critical part of this entire discussion. Seriously. Because while those first two buckets are super common, this third one, cardiac syncope, this is the one that can kill your patient. This is where we, as clinicians, truly earn our keep.
So, it all comes down to this one crucial question, right? When you're in the middle of a crazy shift, how do you quickly and reliably spot the red flags? How do you tell the difference between a simple, harmless faint and a warning shot for sudden cardiac death?
This right here, this is your high-yield cheat sheet for those red flags. So let's break it down. In the history, you're listening for key phrases like fainting during exercise or fainting that comes with chest pain or palpitations. Big red flags. For their past medical history, if you see heart failure or coronary artery disease on their chart, your alarm bells should be ringing. And then the ECG. You're hunting for signs of dangerous arrhythmias. We're talking about things like AV block, a problem with the heart's wiring, a long QT interval, or that classic Brugada pattern. If you see any of these, your default setting has to be, this is cardiac syncope until I can prove it's not.
Okay, so we've got all this great context. Now, what's our game plan? What do we do step by step when a patient who passed out gets wheeled into your bay?
Honestly, it all boils down to 3 fundamental pillars. That's it. Number 1, a super detailed history. And I mean, talk to the patient, talk to anyone who saw it happen, get the full story. Number 2, a really thorough physical exam. You've got to check those orthostatic vitals and do a solid cardiac exam. And number 3, a 12-lead ECG. On everyone, no exceptions. This is the absolute non-negotiable foundation for every single syncope workup you will ever do.
And look, if you ever start to think, oh, it's just another fainting spell, I want you to remember this. This quote says it all. Syncope due to a cardiac cause is associated with an increased risk of sudden cardiac death. Let that sink in. The stakes really could not be any higher.
So I'm going to leave you with this one final thought. Was that episode a simple feint, or was it a warning sign of impending sudden death? The thing is, a careful, structured, and really thoughtful workup built on the exact principles we've just talked about, that is what makes all the difference in the world.